Let's talk a little bit about cardiovascular system assessment. When you start with the patient history, you're going to want to know things like their social history. We want to know what kind of living situation they're in. Do they have a domestic partner? Who else is in the household? What kind of environment they're in on a regular basis? What do they do for a living? We need to know all of those things. What kind of support system do they have? To an extent, we're going to have to know a little bit about their finances, just to know if they're able to afford their medications or not, or is that one of the problems that keeps bringing them in with cardiovascular issues? They can't pay for their meds. So, yeah, about the job. A lot that we need to know about that job, especially if they're having symptoms that we'll learn about here in just a minute. But is it a physical job? You know, are they lifting heavy objects? Is their job stressful? And what do they do in a day's time? Okay, for your nutritional history, you may want to have your patient recall their food and fluid intake for a 24-hour period. And if you can share this with your dietitian, you can provide the patient with a little bit more information about the sodium, sugar, and cholesterol intake that they're having normally, as well as the fiber and fat. And that way you and the dietitian will be able to guide them a little bit better into a healthier nutritional intake. We always want to take into consideration cultural beliefs, especially when it comes to nutrition, and economic status as well. So somebody that couldn't afford to go out and buy their medication may not be able to go out and buy as many fresh fruits and vegetables as you're asking them to. So we have to kind of adjust our nutritional guidance according to how much they can afford as well. Okay, with family history, age, and of course their health status and the cause of death of immediate family members is very important. It may surprise you to know that coronary artery disease in someone that's in first degree related to you, so your parent, your sibling, or your child, is a major risk factor. It's even more of a risk factor than if the patient has hypertension, if they're obese, if they've got diabetes, or even sudden cardiac death. These are more important. It's the familial or genetic risk is more important than these other things to look at. You're going to ask the patient to describe his or her health concerns, and then you're going to dig deeper into anything that the patient tells you. So some things that you might come across that could be a symptom of cardiovascular disease would be things like chest pain or even chest discomfort, shortness of breath, fatigue, palpitations, weight gain, syncope, and even extremity pain. Okay, so pain and discomfort in the chest could be a result of ischemic heart disease, pericarditis, or even an aortic dissection. Unfortunately, there are a lot of other things that can cause you to have chest pain as well. So, you know, diving in and getting a really good description of what their chest pain is like is super important, because it could also be pleurisy, a PE, hiatal hernia, some kind of gastric reflux problem, or just anxiety. I mean, there are a lot of things that can cause chest pain. So anytime you have a patient with pain, we've talked about assessing pain before. You're going to do the same thing with this type pain. You're going to ask them when did it occur first? What kind of precipitating factors? Where is it located? Does it move from this area to another area? Is it sharp? Is it dull? Is it crushing? You're going to have them rate it between 0 to 10. On a numeric pain scale if you can, or some kind of pain scale. Is there anything that goes along with it? Do you get short of breath? Are you diaphoretic? Have you not had nausea and vomiting with the episode? Is there anything that makes it worse? Is there anything that makes it better? So when we think about shortness of breath or dyspnea, both cardiac and pulmonary disease can cause shortness of breath. So we have to ask our patient, is it uncomfortable breathing, or do you get short of breath when you're doing your activities of daily living? Do you have shortness of breath on exertion? That's dyspnea on exertion, which is usually an early symptom of heart failure. And it actually may be the only symptom of heart failure that they have. Do they get short of breath when they're lying flat? That's called orthopnea, and that's, indicative of heart failure as well. Ask them how many pillows they sleep with. That'll give you a good idea if they're orthopnic or not, because sleeping on several pillows will relieve that orthopnea in a lot of people. Do they have paroxysmal nocturnal dyspnea? So that means that they've been lying down for several hours and then they wake up short of breath all of a sudden. And what happens is when they lay down, the blood that has been kind of in their periphery, especially the lower legs, is redistributed back into the venous system. And that increased volume in the venous system puts a little bit of stress on the heart, and the heart just can't compensate for that increased volume. And what happens is you'll get pulmonary congestion, and the patient's going to wake up abruptly. They're going to feel like they're suffocating or panicking. When they sit upright and they dangle their legs over the side of the bed, after a little bit it relieves the symptoms. Well, why would that be? Because that fluid shifts back into the edematous type areas of the leg and out of the vascular system. So their heart is not quite as stressed as it was. So what if they have tiredness or weakness? We need to ask them about fatigue. Although that's not by itself a diagnostic of heart failure for sure, a lot of people with heart failure do have fatigue, especially leg fatigue during exercise. So fatigue that occurs after mild activity and exertion can indicate inadequate cardiac output due to a low stroke volume. And remember, your cardiac output is your heart rate times stroke volume. You're going to ask about the time of day the patient experiences the fatigue and what they're doing when they experience the fatigue. Cardiac output is often lower in the evening in these people with cardiac problems. I'm going to ask them, compared to a year ago, how much can you do now without getting fatigued? Can you do about the same amount, or can you do less than you were able to a year ago? Ask them about palpitations. Do they have an unpleasant feeling in the chest? These can occur from a change in the heart rate or rhythm and an increase or decrease in the contractility of the heart. So there are a few rhythm disturbances that can cause palpitations, and we're going to learn more about rhythms in our critical care component the last semester, but paroxysmal supraventricular tachycardia, PVCs, and just a sinus tach that's paroxysmal can make them feel like they're having palpitations. All right. Does it happen after, a lot of physical activities? There are some non-cardiac factors too that can precipitate palpitations, like anxiety, stress, if you're really, really tired, if you haven't slept well, hyperthyroidism. Of course, caffeine and nicotine can always be contributing factors as well. So A sudden weight increase is the best indicator of fluid retention. So another way to say it is the best indicator of fluid balance is going to be weight. And I think we've talked about that before. Excess fluid is going to be known as edema. And the thing about excess fluid is it's a little tricky because you may gain 10 or 15 pounds before you start seeing edema occur. So having the patient weigh themselves daily, especially with congestive heart failure, is going to be really important teaching for that type patient. Syncope, which is just passing out, it's a brief loss of consciousness, indicates some kind of interruption to perfusion in the brain. And anything that can suddenly decrease cardiac output and cause it not to be pumping blood well to the brain can cause syncope. And it could be anything from a cardiac dysrhythmia, especially some ventricular dysrhythmias. It could be a valvular disorder, or even aortic stenosis can trigger these symptoms. So extremity pain, anytime you're not getting blood to a muscle, whether it's the heart or the legs or whatever, it can cause pain. So lack of oxygen to a muscle, which is ischemia, maybe from sclerosed arteries, or even maybe from venous insufficiency, can cause pain. Now let's talk about intermittent claudication right quick, and that's related to decreased arterial tissue perfusion. So basically it's that area that doesn't get blood, doesn't get the oxygen that it needs, and you're going to have cramping, especially in the lower legs. Just resting or lowering the affected extremity to decrease the tissue demands for oxygen or to enhance the arterial blood flow usually will relieve claudication pain. So leg pain that results from prolonged standing or sitting is usually related to venous insufficiency. And that could be incompetent valves or even a block in the venous, in the vein somewhere. And elevating the extremities will help for that. So if you want to know the difference between intermittent claudication, which is related to the arteries, or venous insufficiency, if you have pain in those legs and you're not sure which it is, elevate the legs. If it's relieved, it could be either one, venous insufficiency or intermittent claudication. But if it goes away with just resting the lower affected extremity and hanging it down, then it's probably arterial blood flow issue, and that would be intermittent claudication. Okay? Does that make sense? If not, you better be asking me. Okay, so we pointed this out. The best indicator of fluid balance is weight. 2.2 pounds equals 1 kilogram equals 1 liter of fluid. You're going to need to know that. So in assessment of the physical assessment of the cardiovascular system, let's talk about that a second. In assessment, of course, the general appearance you're going to take in as soon as you walk into the patient's room. What is their build? What's their skin color looking like at first glance? Do they appear to be in distress? Are they awake, alert, and oriented? Do they appear shortness of breath? What position are they in? Are they leaned over in tripod position? Are they sitting up straight? Are they slumped? What's their verbal response like? A lot of times when you get decreased perfusion to the brain, you're going to see confusion, memory loss, a slowed verbal response, especially in older adults. They can also appear malnourished, thin, and with right-sided heart failure, you're going to see ascites, jaundice, and anasarca, which is just generalized edema as a result of prolonged congestion of the liver. But we're going to look at that more in the next chapter, the difference between right-sided and left-sided heart failure. Let's talk about skin assessment right quick. Skin assessment is going to include the color and the temperature. Look, people, you got to be touching your patients. You need to be assessing from one extremity to the other, touching both arms at the same time, touching both legs at the same time, assessing the temperature. So a normal blood flow in light colored skin appears pink and rosy and warm. Decreased perfusion, you're going to see cool, pale, and moist skin. And pallor is because of the anemia, and you can, or perfusion, either one, anemia or perfusion problems, and you're going to assess that best in the nail beds, the palms, the conjunctival mucous membranes, and you can do that in any patient of any color and any nationality. So that bluish tinted skin is called cyanosis, and it's not an early sign of decreased perfusion, but it actually usually occurs later with other symptoms. And of course, we've learned about assessing the skin of the dark-skinned adults, but remember that cyanosis can appear kind of as a graying of the same tissue in the darker skinned adults. All right, central cyanosis is a decreased oxygenation of the arterial blood in the lungs, and it appears as a bluish tinge in the conjunctiva and mucous membranes of the mouth and the tongue. And it can be because of impaired lung function, but it could also be a right to left congenital heart problem. Okay. So why is the skin blue? Because there's a marked desaturation of the hemoglobin in the peripheral tissue. And this makes a blue color in the nail beds, the earlobes, the lips, the toes. So peripheral cyanosis, let's say that it's just on one side. That could be due to a constriction of the arteries on that side. You're going to make sure that you're checking pulses in the extremities for this. But bilateral cyanosis could mean a general decrease in cardiac output. Or for some reason the oxygen is being extracted from the blood. And one thing that comes to mind is that hurricane spray that we learned about. Rubor. Rubor is a dusky redness that replaces pallor in a dependent foot, and that would suggest arterial insufficiency. So rubor is just a dusky redness. I told you should be touching your patients. You should be comparing that skin temperature from side to side at the same time. And usually, you know, the back of your hands is a better way to assess the temperature than the palmar side. So turn your hands over and feel both of those legs, both of those arms, both sides of the body, just to make sure that the temperature is the same. You can have problems with the temperature not being the same in heart failure. You could have it in peripheral vascular disease and even shock. Usually with heart failure and shock, you're going to have it bilaterally about the same, like all extremities are cool. But with peripheral vascular disease, it depends on where the blockage is. Okay. All right, with the extremities, you're going to look for clubbing of the nail beds, which is caused by chronic deprivation of oxygen to the tissue there. And with clubbing, the nail beds will be the nail straightens out to an angle of 180 degrees, and the base of the nail becomes spongy, so it's kind of humped over, and you can actually look at a picture. Let me see if I can find it in our book here, and I'll tell you what page it's on. Sorry, it was in another chapter. It's on page 576, and it's figure 30-10. Gives you a really good visual representative of clubbing in the fingers. So you're also going to be talking about assessment of edema in the extremities. You're going to be assessing the mobility and the skin turgor as well. Okay, you're going to be assessing, do they have muscle fatigue or pain in those areas? Is there any numbness? Are the extremities cool to the touch? What about the hair distribution on the legs or the arms? Is there some kind of blockage there? Let's see, what else did I want to... of course, you know how to assess edema, but we will continue to go over that, especially in the clinical setting, which we probably already have by the time I'm making this video. But you're going to see mild, moderate, or severe edema. Is it pitting? Is it non-pitting? Okay. All right, let's talk about blood pressure a little bit. Hypotension and hypertension. Hypertension would be a systolic pressure of 140 or higher, or a diastolic pressure of 90 or higher. Hypotension would be a blood pressure less than 90/60. And if it's less than that, it may not be adequate for providing enough oxygen and nutrients to the body cells, so the perfusion would be greatly decreased. Okay, postural or orthostatic hypotension is when you have a change, a drop in blood pressure of 20 systolically or 10 diastolically whenever you change positions. And there are many different things that can cause postural hypotension. A lot of drugs can. If you're dehydrated, you know, your blood volume, your total blood volume is decreased. If you've been in the bed for a long time, some age-related changes can do this, or some nervous system disorders also. So when you're doing a orthostatic blood pressure, you need to lay the person flat or supine for 3 minutes. Note that, 3 whole minutes. Then you take their blood pressure. Then you sit them or stand them on the side of the bed. Make sure you're standing beside them for fall precaution reasons. And you have to let them stand there for 1 whole minute before you take their blood pressure. The patients are going to argue with you sometimes, but that is the definition of an orthostatic blood pressure. So you want to make sure that you leave the blood pressure cuff on the patient so that right when a minute comes, you can be taking that blood pressure. And you need to also be taking the radial pulse along with it, because a 10 to 20% increase in the heart rate when they change positions is also significant. Okay, so let's go on to the next slide here. In our precordium assessment of the patient, that's just assessing the area over the heart. You can do inspection, palpation, percussion, and auscultation. Until you get to be an advanced nurse, you'll just be doing inspection and auscultation. So let's talk about those two. First of all, you're going to put the patient in the supine position with the head of the bed slightly elevated. And some people may actually have to have it elevated quite a bit for their breathing. So just kind of know that you may have to change that around a little bit, but ideally supine with just a little bit of the head raised. You're going to inspect the chest from side to side, looking for any kind of little vibration that you note in the chest, or any kind of movement there that's unusual. Your text says movement over the aortic, pulmonic, and tricuspid area is abnormal. So feeling a pulse in the mitral area is normal and is actually called the point of maximal impulse. And that is one of the only times as a beginning nurse that you're going to be actually percussing or palpating, not percussing, I'm sorry, palpating the chest, is to feel for that point of maximal impulse. And that is over the mitral area, the mitral valve area. On page 654, you can kind of see the different areas that we're going to listen to and to assess the heart. And you can see the aortic valve area in the second intercostal space to the patient's right of their sternum is where you're going to listen for the aortic valve. On the other side of the sternum, the pulmonic valve can be heard. The right ventricular area is located over the lower half of the sternum. You can see it there on the picture. And then the mitral valve area is located in the fifth intercostal space, mid-clavicular, on the mid-clavicular line. So you go halfway between the clavicle, the middle of the clavicle, and feel down until you can feel the fifth intercostal space, and that's your mitral valve area. We may have to adjust, move around a little bit for a lady's breast. And that doesn't mean you listen in a different place. You just may have to move her breast around a little bit to be able to listen. And of course, this is always done respectfully and with permission only, okay? So auscultation, you're going to be evaluating the heart rate and rhythm, both systolic and diastolic, and valvular functions. You need a really good stethoscope for this, and I'm sure that you all have one by now. You're going to listen to the heart sounds in a systemic order with every patient that you have, okay? You're going to listen first in all of these areas with the bell. The diaphragm, your regular side, the diaphragm of your stethoscope, and then you're going to repeat the steps with the bell of your stethoscopes, because these two sides of the stethoscope, you can hear different tones, okay? So some are high-pitched, some are low-pitched, and you can hear different tones with the different sides, so you need to assess with both. The first heart sound, the lub, is S1, and it's created by the closure of that mitral and tricuspid valves, and it's usually softer and longer, and it's kind of low-pitched. The S2 is the dub portion, and that's going to be when you hear those aortic and pulmonic valves, those semilunar valves closing. And you've already seen some of that in the videos that you've watched, and we're going to have another one here in just a second about heart sounds, normal heart sounds, okay? Let's talk about abnormal heart sounds. You can have a paradoxical splitting of the S2 sound. This is just where you have some really severe myocardial depression that causes an early closure of the pulmonic valve or a delay in aortic valve closure. And this can happen in things like an MI, left bundle branch block, aortic stenosis, aortic regurgitation, and right ventricular pacing. And so basically you hear a longer sound with S2. So instead of lub-dub, well, I'll tell you what, I'm going to do some videos that will give you some examples so you'll be able to hear it, okay? Gallops and murmurs are pretty common. So S3 and S4 sounds are sounds that are made in the heart when the blood enters a non-compliant chamber during the rapid ventricular filling. S3 is produced during the rapid passive filling phase of the ventricle and when blood flows from the atrium to a non-compliant ventricle. I'm going to give you examples of these as well. It's usually because of vibration of the valves and the supporting structures. And the fourth heart sound occurs as blood enters the ventricle during the active filling phase at the end of ventricular diastole. Okay, so S3 is considered a ventricular gallop and S4 is considered an atrial gallop. And these are really not super easy to get used to listening to unless they're very pronounced. Murmurs can happen. This is because of turbulent blood flow through normal or abnormal valves, and they will be classified according to when they happen in the cycle of the heart. So is it a systolic murmur? If it is, then that may be aortic stenosis or mitral regurgitation. And this occurs between S1 and S2. So it would be, instead of lub-dub, it would be lub-swish-dub, 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 okay? And that would be the murmur in there. Diastolic murmurs could be mitral valve stenosis and aortic regurgitation, and it occurs between S2 and the next S1 sound, okay? So it'd be lub-dub swish, lub-dub swish, lub-dub swish. So murmurs can happen, you know, throughout the cycle. You just have to listen really closely to try to identify, is it a systolic murmur or a diastolic murmur? So pericardial friction rub is when the pericardial sac and the movement of the heart during the cardiac cycle rubs together. And usually it's a sign of pericarditis, inflammation of some type. It can be heard in pericarditis resulting from an MI, from cardiac tamponade, or a post-thoracotomy. Okay? Let's talk about blood work and what we can associate with myocardial damage. Okay? There are some enzymes and some proteins that we can measure when a patient's having an acute myocardial infarction, which is also known as acute coronary syndrome. And the first one is troponin. It's a muscle protein that's specific to the myocardium. Okay? There are different kinds of troponins. One is T and one is I. And they're not found in healthy patients. So any rise in these values indicates some kind of cardiac damage. The timing of the troponin, both T and I rising, are different. So somebody could come in and be having an acute MI, and it takes just a minute for that troponin to rise, okay? So you're going to want to get an EKG as well for these people having chest pain, and you're going to follow that initial troponin with another troponin check in 3 to 6 hours. You can also check a CK and a CKMB, and those used to be the diagnostic tools that we would use for myocardial infarction, but they're no longer recommended to use those because we have a more sensitive troponin that we can use now. When we're talking about coronary artery disease, lipids come to mind because an elevated lipid level is considered a risk factor for coronary artery disease. So these aren't acute readings that we would usually get to see if they're having an acute MI, but they are part of a workup that you would do for a cardiac patient. These would include the cholesterol, triglycerides, and we would want to check the LDL and HDL, which are types of cholesterol. So your total cholesterol should be less than 200. The triglycerides should be between 40 and 160 for men and 35 and 135 for women. HDL should be more than 45. So that's your good cholesterol. And you can think of H as high. We want it to be high. HDL, we want high, so greater than 45 for men and more than 55 for women. And then your LDL, we want it to be low, L, low. So we want it less than 130, okay? Homocysteine levels can be checked as well, and elevated values can be considered risk factor for cardiovascular disease. Elevated levels of homocysteine you can look at it kind of like smoking and hyperlipidemia, especially in women. So if you have elevated levels, that might indicate that you're at greater risk for cardiovascular disease. Okay. The C-reactive protein is a marker of inflammation. So there's a highly sensitive C-reactive protein, and if the C-reactive protein is over 3, that puts the patient at high risk for heart disease. And it could be elevated because of hypertension or infection or even smoking. Okay. Microalbuminuria, that's small amounts of protein in the urine. It can be definitely a marker of widespread dysfunction in the endothelial tissue, okay, along with the elevated CRP. So this would be just an annual screening that the patient would do. We wouldn't do it in acute care setting necessarily. But if somebody has hypertension or metabolic syndrome or diabetes, they need to be checked. Their urine needs to be checked for protein at least once a year. Because not only is it a cardiovascular disease marker, it's also a renal disease marker, which you can have those renal problems a lot in patients with hypertension and diabetes. So the blood coag studies, the PT, the INR, and the PTT, you're going to check these with the medications that you might give some of these people, like Coumadin. So what goes with Coumadin? The PT and INR, right? And what goes with heparin, PTT? You might also want to do ABGs to determine the tissue oxygenation and the carbon dioxide removal, as well as the acid-base status, to make sure that you're treating the patient appropriately. Fluid and electrolyte balance is always something to take into consideration when you're talking about potential heart failure or cardiovascular disease of any kind. So electrolyte imbalance specifically can cause a lot of problems. So the cardiac effects, think about the cardiac effects of low serum potassium. What's going to happen there? You're going to have some electrical instability, ventricular dysrhythmias, and an increased risk for digitalis toxicity. Remember, when your potassium is low, your dig can get out of whack as well. Hyperkalemia can make slower ventricular conduction. You're going to see peaked T waves on the EKG and contractions followed by asystole or cardiac standstill. Hypocalcemia, you're going to see ventricular dysrhythmias, a prolonged QT interval, and maybe even cardiac arrest. Hypercalcemia shortens that QT interval and causes atrioventricular block, digitalis hypersensitivity, and cardiac arrest. And then, of course, your sodium values are going to influence that fluid balance more and more, and that's really important with patients with heart failure. And it talks about magnesium here as well. Magnesium plays a part in the electrical activity of the heart, and low magnesium can cause the patient to go into torsades. And so anytime you have a patient that goes into torsades, the first thing you want to do is take care of that rhythm, which is usually to shock them back. But then you want to check the magnesium level right away and make sure that your mag is at an acceptable level. Okay, that's really all I wanted to talk about there. I'm going to let you read on through about the H&H and leukocyte count. That's page 657, chapter 33. That first big column down at the bottom there. Make sure you read about H&H and leukocyte count. Alright, we're going to do a PA and a lateral chest. What does PA mean? It means posterior to anterior. So the patient, if they're standing, will be facing against the board and the machine will be behind them to take the picture. So they're going to do a PA and a left lateral view of the chest, and they're going to look at the size of the heart there and the silhouette of the heart. Is the heart enlarged? Can they see pulmonary congestion? Are there any calcifications in there that they can see? And of course they're going to evaluate on a chest x-ray also in acute care, critical care, any endotracheal tubes, any kind of CVP lines or whatever monitoring devices. So angiography or arteriography are just tests where they inject the contrast medium to see if there are any blockages or narrowing or an aneurysm, something like that. And these are like in your heart caths. That's when you will see this. And speaking of cardiac catheterization, that comes next. It can include studies of the right or left side of the heart and the coronary arteries. So let's look on table 33-4 down there at the bottom of page 657, and it'll give you some of the indications for a cardiac cath. If you suspect a heart disorder, of course, including congenital abnormalities, coronary artery disease, myocardial disease, valvular disease, and valvular dysfunction, and to determine how bad is the disease. You're going to assess stable but severe angina that's unresponsive to medical management, uncontrolled heart failure, dysrhythmias, acute myocardial infarction, to decide what the best therapeutic option is. Do we want to put a stent? Do they need to be opened up for a coronary artery bypass graft? Which is referred to as a CABG, and we want to be able to evaluate the effects of medical or invasive treatments on cardiovascular function as well. Here's just a picture of the cardiac cath. A lot of times they're going in through the radial artery now, but this shows the femoral artery down there. And if you went in through the femoral artery down there and went up to the heart, what would you be coming through? The aorta. You would go all the way up into the aorta. Well, why would you do that? Why would you do that? It's because the coronary arteries branch off of the aorta right after that aortic valve. So you see, if they put that catheter up there, they can go into either the right coronary artery or the left coronary artery and shoot some dye in there and be able to see what's going on in those coronary arteries. You see the picture there on the left that shows where the catheter has gone up through the aorta right over to right above the aortic valve there. Okay, we're going to learn about how to read EKG strips and all of that at a later time in our last segment. Sorry, I got distracted there for a second. In critical care, and you can also have electrophysiologic studies done on the heart. Those EPS studies are done, and what they do is they recreate the problem you've been having, whatever arrhythmia you've been having, so that they can diagnose and treat the problem. It is a very controlled environment that these studies are done in, and immediate treatment is available for adverse reactions, but it can be dangerous. Can have stress tests done to determine if there is any kind of cardiovascular problems, especially with the coronary arteries. You can also have pharmacologic stress tests done, and these are often done with dobutamine. And basically what you do is you hook up the patient just like you would for a normal stress test, but instead of having them walk on the treadmill, you inject medication to increase their cardiac output, just like you would just like what you would get from exercising, but you just do it with medication. The TEE is a transesophageal echocardiography. So basically what they do is they do an echo through the esophagus, and what they do is they can really see the back of the heart, because the esophagus goes right down behind the back of the heart. They run this little thing into the esophagus so that they can get really detailed pictures of the back of the heart. The left atrium, the mitral valve, and the aortic arch especially. So what you would do for these would be the same kind of stuff you would do for a GI scope, and we'll talk about those over in chapter 52. Myocardial nuclear perfusion imaging. I just had one of these done, and there really wasn't that much to it. Basically, you had to be without food or drink. They made me do it the night before, but your book says for 4 hours. And actually, they had me do without caffeine the whole day before. So they injected the stuff in, then I had to wait, and they would do some imaging. Then I had to wait a little bit longer, and they would do some imaging. But it was pretty interesting type deal they did there to look at the function of the heart. And it really is for identifying things like an MI, but also just like blood flow and any kind of ventricular abnormalities where it just wasn't pumping out, you know, your stroke volume wasn't good. Your next couple of videos will be on heart sounds, okay? Do the best you can to listen And it's kind of like what I'll say on there, I believe I told you, is it's like counting money. Like people in banks, they have them count money over and over and over again so that they learn to very quickly identify any counterfeit money in there. If you will listen to cardiac tones over and over and over again on all of your patients, even if you don't really understand them fully at first, then when you hear something abnormal, you will identify that and you'll be able to at least say, hey, Doc so-and-so, can you take a listen to Mr. So-and-so? I hear something in here. And he may know something about their history that tells you exactly what it is.